To prevent hypoxic brain injury during labor, clinicians rely on the cardiotachograph, or CTG. It is built for high sensitivity, designed to catch any deviation in the fetal heart rate, but that safety margin comes with a severe lack of specificity. In modern clinical practice, the CTG machine carries a false positive rate for fetal acidemia as high as 98%. This high frequency of false alarms drives a cycle of unnecessary emergency C-sections and operative interventions on babies who are not actually in distress. When a CTG trace becomes pathological, practitioners cannot rely on the heart rate alone. They must deploy adjunctive tests to verify the baby's metabolic state. These secondary checks typically fall into 3 categories. 1. Vibroacoustic stimulation. 2. Fetal scalp blood sampling. And 3. Non-invasive fetal ECG. Differentiating between a false alarm and a genuine emergency requires moving past blind protocol execution and into the underlying physics of these diagnostic tools. The simplest non-invasive step a midwife might take for a non-reassuring CTG is vibroacoustic stimulation. The device emits a sound wave ranging from 82 to 120 decibels through the maternal abdomen. This mechanical stimulus is intended to induce a startle reflex in the fetus, which should trigger an immediate acceleration in the heart rate. The theory suggests that a reactive acceleration proves the fetal central nervous system is intact and currently resisting severe hypoxia. But when the Cochrane collaboration analyzed the data behind this practice, the clinical reliability was not supported by the evidence. Protocol variability across these studies is massive. Researchers used frequencies from 20 to 9,000 Hz with no standardized duration, making the results highly inconsistent. Despite its non-invasive appeal, VAS lacks the randomized evidence required to rule out fetal distress. For decades, the standard invasive follow-up has been fetal scalp blood sampling, designed to measure capillary pH and lactate directly from the fetus. A practitioner uses a lancet to scratch the fetal scalp and draw a microsample of blood into a glass capillary tube. If the analysis returns a pH below 7.20, the protocol mandates immediate operative delivery. This logic relies on the assumption that the scalp accurately reflects the baby's systemic condition. During a hypoxic event, a fetus initiates brain-sparing circulation. It actively diverts oxygenated blood away from peripheral tissues to protect the brain, heart, and adrenal glands. By sampling the scalp, the practitioner is testing a non-essential peripheral tissue that the fetus is actively starving of blood flow to survive. There are also mechanical points of failure. Alkaline amniotic fluid can contaminate the droplet, neutralizing acidotic blood and creating a falsely reassuring result. Furthermore, sampling over an area of scalp edema, known as caput, traps stagnant acidotic blood that does not reflect the baby's central state. Relying on scalp sampling focuses on a compromised peripheral defense mechanism rather than the central metabolic state of the fetus. We can see this physiological mismatch in the data. A retrospective study evaluated how scalp sampling actually compares to umbilical cord outcomes at birth. Obtaining viable paired samples is notoriously difficult. Out of over 2,200 initial cases, only 407 provided reliable data for analysis. In successful cases, researchers analyzed the predictive power of an abnormal scalp pH against true neonatal acidemia. The test shows a high negative predictive value. With a specificity of 85.5%, it is an effective way to rule out acidemia in healthy babies who have a confusing CTG trace. However, the sensitivity is only 28.6%. This means scalp sampling will miss the vast majority of true positive cases of fetal acidemia. Because the test fails as a rule-in tool, midwives require technology that monitors the central organs directly. Reliable intrapartum surveillance avoids peripheral tissues and monitors the primary central organ, the fetal heart. This is achieved through non-invasive fetal electrocardiography, or NIFECECI. This setup uses standard ECG electrodes placed across the maternal abdomen to capture the electrical activity of the fetal heart. The microvolt signal of the fetal heartbeat is typically completely buried underneath the massive maternal electrical signature and muscle noise. To unmask the fetal signal, engineers use a process called independent component analysis, or ICA. By separating waveforms based on their statistical independence, ICA isolates the fetal ECG into a clean, readable trace. This allows clinicians to analyze the morphology of the fetal ST segment in real time. When fetal hypoxia begins, the heart begins myocardial glycogenolysis to generate energy. This metabolic change physically shifts the ST segment, causing it to elevate or depress. This provides a continuous measure of central metabolic compensation, bypassing the failures of peripheral tissue sampling. These two adjunctive tests represent two different approaches to the same clinical problem. Fetal scalp blood sampling provides an invasive snapshot of a peripheral tissue currently undergoing defensive vasoconstriction. NIF-ECG provides a continuous, non-invasive stream of data from the heart as it actively compensates for a loss of oxygen. The role of the clinician in this setting extends beyond the execution of legacy unit protocols. Correctly evaluating a pathological CTG requires a grasp of the physiological reality occurring behind the data. Modern intrapartum fetal surveillance moves beyond mechanical startle reflexes and peripheral sampling to capture the direct electrical signature of fetal compensation.